Hello, everyone. My name is Howard Grant, CEO of Ley Health System. Here's something you've probably heard before, but this time it's coming from a pediatrician and hospital CEO. Healthcare costs in Massachusetts are outrageously high and frankly unsustainable. We have the highest healthcare costs in the nation, 36% higher than the national average, to be exact. Even if you factor in our higher cost of living, it only justifies about half of the gap. Every citizen in Massachusetts spends about $2,500 more per year for health care than residents elsewhere. In fiscal 2014, the Commonwealth spent $2.8 billion more for health care than it spent in fiscal year 2004, an increase of 21%. During that same time, the Commonwealth spent $1.4 billion less per year for education, for transportation, for infrastructure, for public health, and public safety, a decrease of 7%. So what's wrong with this picture? Think what each of you could do with an additional $2,500 every year. Think what the state could do with several billion dollars reallocated to non-healthcare related needs. Think about the failures of our public transportation system during the snowfalls of this past winter. Plain fact, we are cannibalizing our children's future to feed the industry of which I'm a part. You've likely heard these numbers before, and like many, you may believe there's nothing you or we can do about it. It's too complex, it's inevitable, it's an insider's game. Some even suggest it's necessary. Well, don't believe it. We can do something about it. It's not too complex. We can solve this problem, but we have to do it together. To be fair, good health care is really expensive, and we are fortunate in Massachusetts to have superb hospitals, physicians, and insurers. Some drivers of this expense, like new technologies and an aging population, are unavoidable. But generally, these are national drivers. None of them explain why our costs are so much higher than the rest of the nation. Something else is driving this enormous discrepancy. What drives this gap? It's actually relatively simple. Residents of Massachusetts receive superb care, but all too often they receive that care in the most costly setting possible. Now let me explain. Teaching hospitals, we call them academic medical centers, are designed to treat the most complex patients and are constructed, equipped, and staffed for just that task. By definition, and for a variety of different reasons, such as investments related to education and research, they cost more to run than community hospitals, whose patients are often not as complex. To illustrate, a knee replacement in your typical Massachusetts community hospital with superb clinical outcomes costs around $29,000. The exact same procedure at Boston academic centers average $36,000. Nationally, only 16% of all Medicare hospitalizations are in academic medical centers. In Massachusetts, that number is 40%. 16 versus 40%. Is that because we're sicker? Of course not. In fact, in Massachusetts, we have a healthier population than 47 other states. Is it because patients receive better care in those hospitals? Absolutely not. Several state studies dismissed that claim and found that higher-priced providers do not score better on quality measures. In fact, the Massachusetts Attorney General concluded that price variations are not correlated to quality of care. We are paying more, but it's not for higher quality. Over the last 50 years, nearly half of the Commonwealth's acute care hospitals have closed, with 35 having fully closed since 1980. In 2014, Both North Adams and Quincy lost their hospitals. And this year we learned that Lynn will lose its hospital, each an economic engine and health resource for its community. Yet we've never lost an academic medical center. In any rational and competitive market where educated consumers purchase services on the basis of quality and price, history would reverse itself. Beds in community hospitals would increase, or at least stabilize, while beds in academic medical centers would decrease. But the Massachusetts market is neither rational nor competitive. I want to be clear. We have world-renowned academic medical centers in Massachusetts that have spectacular research and education programs. And we benefit from many innovative, high-quality clinical programs. But way too much of our hospital care is delivered in these higher cost settings with no measurable value to our citizens. Why have we ended up accepting such a dysfunctional system for which we pay so dearly? Why do we perform hernia repairs and simple hip replacements in facilities designed, built, operated, and priced for organ transplants and serious trauma? But before I answer that, let me first describe for you what we have been doing at Ley Health to place our patients in settings most appropriate for their needs. A bit of history. Lahey Hospital and Medical Center, a teaching hospital located in Burlington, has a satellite medical center in Peabody. Before Lahey Health System formed in 2012, if a patient arrived in the Peabody emergency room with an injury or medical condition that could not safely be cared for in its small inpatient unit, after stabilization, that patient would have been transported 16 miles down Route 128 to Lahey Hospital instead of going 7 miles north to Beverly. Fast forward. Beverly Hospital and Lahey Hospital are now together in a system. That same patient is encouraged to receive her hospital care at Beverly Hospital, and increasingly, most do. The amount paid by that patient and her insurer at Beverly Hospital is about 20% lower than for treatment of that same condition at Lahey Hospital, a teaching hospital. We are filling beds in lower cost, high quality community hospitals like Beverly and Winchester and caring for more complicated patients at Lahey Hospital who might otherwise have gone to higher priced academic centers in Boston. Why do we treat far too many patients in unnecessarily expensive settings? Why do consumers and employers and their insurers choose the higher cost settings for most of their hospitalization needs? Here, in my view, are the three biggest reasons. Number one, lack of active consumerism in healthcare. In fairness, the healthcare marketplace will never function like a retail marketplace. In retail, when a consumer makes a purchase, he pays the full cost, all of it. When that same consumer buys healthcare, he shoulders only a very small portion of the cost. Government programs like Medicare and employer-sponsored health insurance insulate the consumer from most of the actual cost of what they are acquiring and using. Consumers will never affect a market the way they would if they had to assume the full cost. But again, this is a national problem. It doesn't explain the particular challenges in Massachusetts. Here, the disparity in the costs of care from which consumers are insulated is quite large. Now, to be clear, I'll defend everyone's right to spend their hard-earned money as they so choose. If you want to ride to work in a limo, have at it. That's your choice. If I choose a less expensive alternative, that's my right. We're both going to get to work just fine. So far, so good. But not good in healthcare. When commercial insurance and our government pay for our care, and the quality of care is equivalent, those of us who choose the less expensive option subsidize those who choose the more expensive option. That's how insurance works. Now, does that seem fair? Not to me. Number two, we built them, we have to fill them. Inside of Route 128, we've got 5 academic medical centers. That's about 3,100 beds. These beds are staffed, equipped, and housed in very expensive facilities funded by tax-exempt bonds, financed by all of us as taxpayers. Removing even some of these beds will be extraordinarily difficult. But as long as they exist, the economics will continue to force high-cost providers to fill those beds with patients who should be cared for with the same high quality in a lower-cost community setting. And number 3, lack of effective competition. The price we pay for health care is far too often totally unrelated to value. This fact, combined with the enormous differential in prices, defines our marketplace. It's been repeatedly documented by our media, by the Attorney General, by the Massachusetts Center for Health Information and Analysis, and the Health Policy Commission that the largest healthcare system in Massachusetts, 4 times the size of its nearest competitor, and with quality metrics no better than the rest, gets paid 20 to 40% more than the rest of the market for the same services. In a normal, rational, competitive marketplace, that system would have to respond with a reduction in price. In a normal, rational, competitive marketplace, consumers would choose other providers who offer the same high-quality services for substantially lower prices. If this was the auto industry and Ford priced its comparable cars 20 to 40% higher than General Motors, guess what? Ford would sell fewer cars. It's basic economics. Yet this large system accounts for more than half the services rendered to commercially insured residents, each of whom pays those high prices with subsidies provided by the rest of us. So if we agree that we've got a very, very expensive problem, how do we solve it? What can be done as providers, insurers, employers, government, and consumers to create a functioning, competitive marketplace to bring us in line with the rest of the country? Massachusetts health systems need to be effective competitors. They need to be bigger in size and geographic scope to develop efficiencies, exercise buying power, rationalize service distribution, manage the health of large populations, and support capital investment. And they need to be committed, not just in aspiration, but in verifiable performance to work relentlessly to place patients in the right settings, with no less quality, but at a more affordable price and with greater convenience to patients and their families. And we all have a role. Government must continue its efforts to promote transparency. Employers and consumers need access to simple price, quality, and patient satisfaction information. Informed choices will lead them to higher quality, lower cost providers. Hospitals and physicians need to be willing to become part of larger organizations that can better manage the health of populations, shoulder financial risks, develop capital, and offer and promote new insurance products to the marketplace. Smaller physician groups and hospital systems will never be capable of mounting the competitive challenges needed to make our market work. Insurers, in collaboration with value providers, must accelerate their efforts to develop and invest in innovative insurance products that attract and benefit consumers who actively choose to receive their care in equal quality, lower cost settings. For those who choose these value-based options, this will reduce the amount of subsidization they pay towards those who choose to receive their care in higher cost settings. Employers have to redouble their efforts to both educate and encourage their employees to gravitate to plans that provide high-value options. And consumers, and that's all of us, have to seek out and use price and quality information to support value-based judgments regarding where we should get our care. Massachusetts residents should be enormously proud that nearly 97% of our citizens rest easy at night knowing that they have health insurance in the event of a serious illness in their family. Over 41 million Americans do not have that security. We must find an affordable path to preserve that coverage and demonstrate to the rest of the country that we can offer insurance coverage to all with high quality and reasonably priced health care. By bringing real competition to the healthcare marketplace, we can maintain access, improve quality, and most critically, reduce costs. By bringing real competition to the healthcare marketplace, we can redirect scarce resources back to education, transportation, and job creation. By bringing real competition to the healthcare marketplace, we will improve the quality of life for us, our children, and many generations to come. We owe it to them. Thank you very much for listening.